Hello everyone, my name is Solafa Omer. I'm going to talk about quality of life assessment in Sudanese women with breast cancer conducted in Khartoum Oncology Hospital 2017. But before that, let me thank all who support me and guide me to reach this point today. As we all know, breast cancer is the most common cancer among females in Sudan and worldwide, and it is a leading cause of death in developing countries and in the world in general. Generally, being born female or getting older are the main risk factors to get the disease, but there are many other risk factors like having a personal history of breast cancer. Many studies have found that taller women have a higher risk of breast cancer than shorter ones, and having dense breast tissue, inheriting certain gene changes like changes in BRCA1 and BRCA2, which are considered the most common cause of inheritary breast cancer. Having certain benign breast conditions like non-proliferative lesions, and these conditions do not seem to affect breast cancer risk, or if they do, the increased risk is very small. Having proliferative lesion without atypia, and these conditions seem to raise the woman's risk of breast cancer slightly, but having proliferative lesions with atypia, these increase the risk more than without atypia or non-proliferative lesions, as the cells in the ducts or lobules of the breast tissue grow excessively. Of course, starting menstrual periods early and going through menopause after 55 are also risk factors. Having your breast to be exposed to certain conditions like radiation and certain drugs also risk factors. We diagnose breast cancer like any other conditions starting by examination. We do breast examination, mammogram, ultrasound, depend on the age of the females, and taking biopsy and histopathology is the endpoint of diagnose breast cancer. And we can do something called 3D mammogram, which is an imaging test that combines multiple breast x-rays to create a three-dimensional picture of the breast. And this mammogram create 3D image and standard two-dimensional mammogram image. And some studies show that combining 3D mammogram with standard mammograms reduce the need for additional imaging and slightly increases the number of cancer, of course, detecting during screening. But more study is needed to understand whether 3D mammograms may reduce the risk of dying of breast cancer more than a standard mammogram alone. A 3D mammogram now is becoming more common, but it is not available at all medical facilities, unfortunately. But it is a good machine in diagnosing and detection breast condition. We treat breast cancer like other cancer, depend on the stage of the disease, depend on the histology of the cancer, depend on the condition of the females. If the female have estrogen receptor, progesterone receptor, or HER2 protein, or if the female has triple negative breast cancer. With triple negative, I mean those has no estrogen receptor, progesterone receptor, or even HER2 receptor. Discovery of triple negative breast cancer agent considered a challenging in oncology because these patients have poorer prognosis, metastatic early and younger patient age. So fortunately, there is new agents for triple negative breast cancer. Unfortunately, breast cancer carry care, but not all female who treated can have a recurrent breast cancer. But there is certain groups, those who have lymph node involvement or those who didn't receive the adequate treatment depend on their conditions, or younger females, specifically those under 35 at the time of their original breast cancer diagnosis, or having inflammatory breast cancer, which is an aggressive form of breast cancer and unfortunately has higher risk to recur again. We can prevent this problem recurrence by treating specific patients by specific treatments, those who need hormonal therapy or targeted therapy specifically for a specific treatment for specific patients. And some studies show that if you give bonding building drugs can decrease the risk of bone metastasis. Of course, maintaining a healthy weight and exercising also can decrease the risk of recurrence of the disease. So, can you imagine how much patients feels about their illness, the side effect of surgery, chemotherapy, radiotherapy, or other medications during their journey of the disease, how trouble they face during doing exercise or daily activity, how much they feel pain, nausea, vomiting, and how much the disease affects the psychological status or social relationships. This is our topic for today and our core of my presentation. By quality of life, we mean physical, functional, psychological well-being, and social support. Disease and treatment can affect both, can affect all these domains. More women are diagnosed with breast cancer, and many clinicians may never witness the long-term consequences experienced by the patients. So, quality of life is very important, and now it is considered an endpoint in treatment of breast cancer. Our objective is to assess quality of life in Sudanese women with breast cancer, depending on international and regional results. Our specific objectives to study the socio-demographic background of the participants, of course, to determine the extent of their functional impact, to determine the association between socio-demographic characteristics, treatment, and quality of life. The study was a descriptive cross-sectional study conducted in 114 Sudanese female participants with breast cancer above 20 years or caregivers above 18 who come to referral clinics of Khartoum Oncology Hospital. Our sample selection was consecutive sample technique. Data collection was interview based. The questionnaire used in this study prepared from European Organization for Research and Treatment of Cancer, Quality of Life 30 and Quality of Life Breast BR23 after little modifications, of course, and the data was piloted to assess the questionnaire acceptance, clarity, and completion time. The questionnaire composed of socio-demographic characteristics, 5 functional skills: physical, emotional, social, body image, sexual functioning, and a global health status, quality of life skills. And all these skills, if the patients have high scores, this is good, and this is what we need for the patients. And the questionnaire also involve single item financial difficulty, multi-item scales to assess systemic therapy side effects and symptoms and pre-symptoms. If the patients have high scores in these, this is bad because this is suffer and this is difficulties. But if the patients have lower score, this is good, and this is what we need for the patients, of course. Analysis of variance was performed to examine the relationship between independent variables and functional and symptom scales of both questionnaires. Going to our result, most of the participants are older, not young, with mean age was 48 plus or minus 0.28. Most of the participants were married. Going to mean difference across quality of life domains. The highest score in questionnaire 1 was for social functioning and emotional functioning, followed by physical functioning and a global health scale. And this may reflect the adequate social and emotional support from Sudanese families and the community in general. Mean difference among quality of life domains in the other questionnaire, and the highest score for body image, followed by sexual and sexual functioning. And this may not reflect the objective result because of Sudanese culture about their acceptance and compliance to these types of questions. For systemic therapy side effects, some symptoms, breast symptom of financial difficulty. The most score that has high mark is financial difficulty, and this is area that took the most concern of most of the patients. So we have to concern and concentrate on these problems and solve it. The other items that have high mark is systemic therapy side effects, followed by arm symptoms and breast symptoms. So financial difficulty, systemic therapy side effect, followed by arm symptoms and breast symptoms. Going to relation between socio-demographic characteristics, surgery and quality of life. Starting by global health status, the best score for the age of 60 to 80, the lowest for 20 to 40, for social functioning, the best score for the age 60 to 80 also, and the lowest for the 20 to 40. For the emotional functioning, the best for 60 to 80, the lowest for 20 to 40. For the body image, the best for the age 60 to 80 also. So our results show that older age has better health related quality of life. And this is result supported by a study done in China found that young breast cancer survivors suffered from worse body image when compared with older women, and younger patients reported to have poorer outcomes. But in counteraction, the study done on Malaysia reported that younger patients had significantly better health-related quality of life if compared to older, and possibly due to that older patients' age. As the disease progresses, they will experience a poor social life with an increased rate of depression and physical inactivity, which could lead to high pain and fatigue level, and thus lower quality of life scores. For marital status, no significant differences and between means of quality of life. Regarding hypertension, also no significant difference between means, and for diabetes, no significant difference across the means, but patients who had diabetes expressed more symptoms than those who do not have diabetes, with p-value less than 0.06. Also, surgery show association between body image, and those underwent surgery scores lower body image scores and thus low sexual functioning. And this is supported by that patients who underwent mastectomy indicated lower body image and sexual functioning than those who did not. And some studies suggest that. In conclusion, Sudanese participants of breast cancer reported good quality of life if compared to other countries, except for financial difficulty, and attention should be given to solve this problem. Our recommendations: quality of life assessment should take more consideration in patient treatment protocol so as to help in improving the quality of life of breast cancer patients, and effort must be done to assess the patient's socioeconomic status and help who need support. Another study should include type of surgery, duration of illness, and duration of treatment that may strengthen the result. And thanks for you so much for your time.